So good morning, everyone. It's my pleasure to welcome you to the first in-person seminar in 2 years for the Cofrin Logan Center for Addiction Research and Treatment. So this is really exciting to be back to face-to-face. For those of you that joined us over the last 2 years on Zoom, we really appreciate all of your attendance and contributions, but it's really great to be able to welcome our speakers back to KU campus. So today, I want to extend a welcome to everyone here who's part of our KU Cofrin Logan Center family, people that are joining us from other departments. And we are also live streaming today on YouTube for hopefully some people from all over the country and all over the world as well. And so what we want to do today is have our seminar speaker, and then we'll have questions at the end. Before we start that, I do want to thank a few people. I want to thank Jennifer Hudson for all of her work to coordinate today. Drew, who you see walking around with the camera, is our wonderful person from Lifespan Institute. Is going to be taking some photos today and also helping with all of the tech issues that we've been having. And then also Hillary Casey for helping us with scheduling today. We have an exciting calendar of seminars and brown bags for the rest of the semester. You can view our website, addiction.ku.edu/events, and follow us on Twitter @addictionku. You can see our upcoming schedule for that. And now it's a real pleasure of mine to introduce a friend and colleague of mine that I've known for many years. And I think the first time we've met face-to-face was actually this visit. But we've been emailing and being connected on Twitter and Zoom meetings for quite some time. So Dr. Bill Stoops is a professor in the Department of Behavioral Science, Psychiatry, and Psychology, and a faculty member at the Center for Drug and Alcohol Research at the University of Kentucky in Lexington. He's the Associate Director for Clinical Research of the UK Substance Use Priority Research Area, or SUPRA. He's the Director of the UK Clinical Research Support Office. His research uses human laboratory and clinical trial methods to understand behavioral and pharmacological factors contributing to substance use disorder and other addictive behaviors. He has a long history of funding from NIH institutes, too many to name. He's also the current editor, and will be stepping down from that position soon, of Experimental and Clinical Psychopharmacology, which many of us publish in. He's a member of APA Council, past president of the College on Problems of Drug Dependence, and I think a testament to his contributions, he was the 2020 recipient of the APA Presidential Citation from the American Psychological Association. I just also want to extend a real special thank you to Bill. He got here yesterday morning, had a busy day of meeting with trainees, postdocs, grad students, even came and met with my class last night. So it's been really great having you here, and you've been so generous with your time. And so without any further ado, I'm going to introduce Bill Stoops, who will be talking about novel cocaine use disorder outcomes and treatment target identification from the human laboratory. Bill.
So thank you, Michael, for that really generous and kind introduction. Thanks to all of you for being here, whether in person, online. It's a real honor to be here. You all have rolled out the red carpet. Oh my goodness, I'm just so happy to be here. So Michael read my title, just a couple of things, and I believe you can see these slides on Zoom. If you have any questions that I don't get to, or you want to know stuff and you don't want to raise your hand, that's totally fine. I get it. Email me. This is my email address. I check it too much. And then I'm also relatively active on Twitter. My Twitter handle is shown on this slide. To do the kind of work, well, maybe. Here, there we go. I'll do this. There we go. Perfect. Got it. No? There we go. Okay. How many PhDs does it take to advance 5? All right. Before I begin, I want to say some thank yous, because to do the multidisciplinary, translational, intensive work we do requires a huge team. So I have 2 primary scientific collaborators, Craig Rush and Josh Lyle, but I'm going to be highlighting work of our past trainees in the lab today. So some of you are familiar with these names: Joe Alcorn, Levi Bolin, Katie Marks, Erica Pike, Justin Strickland, who I understand was here not too long ago. I'm going to be trying to highlight their work today. I also work very closely with physician collaborators, because we do some pretty intensive work in these folks. So Kevin Hatton, Lon Hayes, and Abner Ayapati are the physicians we work with on this project. Of course, we've got a great staff, a great team at our Laboratory of Human Behavioral Pharmacology, or LHBP. Of course, our work is generously funded by NIDA, as well as the University of Kentucky. So I'm going to talk about cocaine use disorder today. And when I first started doing this work, I knew cocaine use was a problem, it was a health concern. But more recently, as we as a field have come to understand health equity and social justice issues around substance use disorder, I think cocaine use disorder is no exception. In fact, maybe is an even more glaring example of a persistent health equity issue. So to do cocaine work, no matter what you're doing, you are addressing health equity. Let me state that very plainly up front. So approximately 2 million Americans report current cocaine use. So they're reporting some type of cocaine use in the last month. That number has been stable for over a decade. No matter what we've done, it hasn't changed that number. But we know that this is actually probably an underestimation because the SAMHSA study is surveying people in their homes. So we are missing people who are criminal justice involved, who are unhoused. So we are underestimating drug use in this country, probably to a great degree. But more importantly, and this is really where my eyes started to be open to this sort of health equity issue, is that this paper was published in 2018. Overdose death rate from cocaine is equivalent, if not higher, in Black people to that of the opioid overdose death rate in white people. So while we're talking about absolute numbers, more white people are dying from opioid use disorder, Black people are dying in just as many, per capita, just as much from cocaine use disorder. And that rate has been in place longer. We're talking since 2000, that overdose death rate. And we've rightfully thrown so many resources at the opioid epidemic, but we haven't done the same for cocaine use disorder. Cocaine overdose mortality is actually increasing, and it disproportionately affects Black people, older people, those with low educational attainment, and it's been made even worse by the COVID pandemic. And this is something that I'm really starting to think more and more about is people who use stimulants, particularly people who use cocaine, experience stigma from people who use other drugs. So the idea that there's no treatment available for cocaine use disorder, people with opioid use disorder, they can go to their doctor and get buprenorphine, which is great, that's wonderful. But they then perpetuate stigma against people who can't go to their doctor and get a treatment for stimulant use disorder. We hear that directly from people with stimulant use disorder. So not only is it a health equity issue and a persistent one, it's also really, really complicated. It's associated with a range of other health problems, acquisition of sexually transmitted infections. A while ago, a number of years ago, we looked at some national data and found that people who use cocaine after you control for injection drug use are 27 times more likely to have HIV than people who do not. Not 27%, 27 times. And it's not driven by injection drug use. They're more likely to be diagnosed with mental health disorders. They're more likely to smoke cigarettes. They're more likely to have cardiovascular problems. So there's all this other stuff that's going along with cocaine use disorder beyond just the use disorder itself. It's also associated with problem behaviors. And that's what I'm going to be focusing on mainly today. And we need treatments. We need treatments that target cocaine use. We need to be thinking about treatments that target these other related issues. Okay, so what do we have? What can we offer people with cocaine use disorder? Unfortunately, not a lot. NIDA says there are 4 behavioral interventions you can use that are manualized, recognized as evidence-based. Cognitive behavioral therapy, community reinforcement with abstinence reinforcement. So this is contingency management, right? Individual counseling and group counseling. And these are variably effective. We know that abstinence reinforcement is the best thing we've got. We have no approved medications. This is a paper we wrote in 2016, and more than 60 medications have been tested across 100 clinical trials. Nothing's been approved. We do know, however, and maybe this is something we talk about a little bit later, that agonist treatment, particularly use of amphetamine, is an effective treatment for cocaine use disorder. Despite that, it has not been adopted or used in the United States or anywhere, really. So let's talk a little bit about how we diagnose cocaine use disorder because it's important for the rest of the talk. I'm not going to read all these to you. But what I have done is I've taken the DSM-5 criteria for cocaine use disorder. There are 11 of them. That people can endorse and then meet cocaine use disorder criteria. And there's a range, but generally the idea is I'm underlining the operational work here. It's all about use, taking more than you intended, trying to cut down your use and being unable to, using in harmful situations or using despite knowing that it's causing you problems. So cocaine use disorder is largely defined by drug taking behavior. And this fits with the FDA definition of what they say is a successful treatment. FDA says if you want to bring forward a treatment to us, a medication to us, it has to promote long-term abstinence, 3 weeks of abstinence, continuous abstinence, no use, no lapse at the end of a trial to a greater degree than placebo. So you have to be directly changing that drug taking behavior and sort of permanently changing that drug taking behavior. And that's really, really hard. And I think that's why a lot of these treatments have failed. You know, for depression, we don't say when somebody is, you know, can't get out of bed for a day, that that's an ineffective treatment, right? There's other indicators. We don't have this sort of absolute end all be all. You have to be perfect. You have to be absent the entire time for you to be considered successful in your treatment. So the FDA has actually been a little bit progressive in its openness to non-abstinence outcomes, but they have said the onus is on us as the research community to bring those ideas forward as drug development tools and to provide the data about this. And alcohol has already done this. For those of you who are familiar with the work that Katie Witkowitz has done, and others, but Katie just happens to be a good friend. And so I tend to think of her when I think about this is the FDA accepts no heavy drinking days as an endpoint for clinical trials for alcohol. So people can still drink, just not drink heavily. And that will be an effective treatment. We don't have that yet for substance use, for other substance use disorders, especially cocaine use disorder. So I'm going to be talking about our human laboratory work. That is just a small piece of how I'm thinking about advancing these non-abstinence outcomes. And a lot of it's because that's most of the work that I've done is this human laboratory work. So why do we do human laboratory work? It's a great way to examine mechanisms of potential interventions and targets of your interventions in a tightly controlled ways. In a tightly controlled way, you can use it within subjects design. That's what we do largely for our studies. So we only have to enroll a very small sample size. And we can efficiently identify interventions and targets before we move to these really big clinical trials that are really, really expensive. And we can do it relatively faster than we can in a clinical trial. So what are our common human laboratory measures? Drug self-administration, which is what I'm going to talk about today. So actually looking at drug taking behavior in the laboratory. And then, of course, another big one is subjective drug effects, right? You give somebody a dose of a drug and you ask them how it feels. And those are, and you can ask about craving. Those are valid and good measures to use. I'm just not really going to talk about those today. I only got about an hour. So actually only got about 45 minutes, but we want to leave time for questions. So I'm going to spend a little bit of time on drug self-administration, but then I'm going to talk about these novel outcomes that we might want to be thinking about advancing as treatment targets. So I'll talk about the commodity purchase. I'm at KU. I got to talk about behavioral economics, right? So I'm going to do that a little bit. I'm going to talk about attentional bias, inhibitory control, and risk decision making. It's going to be a bit of a whirlwind. So hang on. We are in Kansas. Where's Dorothy? I'm going to try to not make it like a tornado, but it might be a little fast. So, okay. So drug self-administration, it's an objective measure of willingness to engage in drug taking behavior. The way we do it in our lab and the way that most people do it in the field is they have individuals sample a dose of drug that's going to be then available later on some sort of scheduled reinforcement. They then have multiple opportunities to take that drug. And usually it's quantified as a single outcome, number of drug choices, break point, sort of whatever your preference is. I tend to think about number of drug choices, but you can use whatever outcome you'd like. We have done any number of behavioral arrangements. We've done FR, we've done PR, we've done choice. But what we really have settled on is starting with the idea of your only drug being available. And that's important because it tells us about the direct reinforcing effects of the drug. But we really like to think about the clinical relevance. And I think doing a choice model where people are choosing between drug and alternative reinforcer is more like the real world. And actually, if you think about it, may even be an analog of contingency management because people are making mutually exclusive choices between taking a drug and earning an alternative reinforcer. Now, there's a lot that goes into this. We are giving people drugs. We are giving people cocaine and we are giving it to them intravenously. A lot goes into it. Simplifying it here by saying anybody that we enroll in these studies, they meet criteria for cocaine use disorder. They provide a benzoylecgonine positive urine sample, which is a cocaine metabolite. So we know that they are using cocaine in the natural environment. We aren't taking people who are cocaine naive and giving them cocaine. None of them are seeking treatment, and all of them are carefully medically screened and housed on a dedicated, closed inpatient unit to undergo controlled drug dosing. So I'm going to just give you one example of a drug self-administration study, and really to sort of show the predictive validity or post-predictive validity, depending on how you think about it, of this approach. So this is a chronic deamphetamine maintenance study that Josh Lyle ran. It was a 12-session study, and we brought people into the unit. We maintained them on 0, 30, or 60 milligrams of oral deamphetamine per day. During experimental sessions, they sampled 0, 3, 10, or 30 milligrams per 70 kilograms of intravenous cocaine, and then made 9 choices between that dose and money, a $6 alternative reinforcer. And this was a concurrent progressive ratio schedule. So under one, cocaine's available, under another, money's available, and the ratio only increases for a previously chosen option. So if they choose drug, that ratio keeps increasing. If they choose money, that ratio keeps increasing. They're mutually exclusive. So here are Josh's primary outcomes from that study. Along the y-axis, I'm showing you number of cocaine choices. Again, the maximum here is 9. Along the x-axis is our cocaine dose, milligrams per 70 kilograms. Let's look at the placebo dosing first with amphetamine. So that's the circles here. This is what we typically see in humans. I know a lot of times in animals, you will see that sort of bitonic dose response curve where it flips over. We don't often see that in humans. So just a monotonic increasing dose response curve such that we get to near maximal drug intake at this high cocaine dose. When we treat them with amphetamine, 30 or 60 milligrams a day, we see a suppression of drug intake, particularly at these lower doses. We don't see as much reduction, but that's pretty typical in humans. It's really hard to knock down high dose cocaine intake in people. But it's pretty good that we see this. This is even hard to get with a lot of drug treatments and interventions. So basically what we're doing is we're getting people to shift their preference from cocaine to that $6 monetary reinforcer. Okay, so how does that map onto what we actually see in clinical trials in the real world? Because to me, in the human laboratory, what your goal is to map the clinical condition. And so if the clinical trial is done well, you then have to meet that. So what has been shown with amphetamine in humans? And I already gave you a sneak preview that it works, but I'm going to show you the data. So this is a chronic deamphetamine maintenance trial. It was a 6-month outpatient trial looking at the same doses of amphetamine we tested in humans, 30 and 60 milligrams of amphetamine per day. And this was in group patients maintained on methadone who were also cocaine dependent. And this is a trial led by John Grabowski and published in 2004. So on the y-axis, I'm showing you the proportion of positive cocaine urine screens. So higher is worse. Along the x-axis, I'm showing you months in the trial. I apologize. I need to get a better. This is on me. This is not on the screen. That is a little blurry. But what I want to just draw your attention to is this triangles here, the 30 to 60 milligrams. So they start out on 30, and then the dose is doubled. And when they get to 60, we're at like 20%, maybe 35% positive urines, which is huge. No cocaine clinical trial other than the original Steve Higgins contingency management trials, the Nancy Petrie contingency management trials, saw this type of reduction. And this was the only intervention from these folks. They weren't getting contingency management. So amphetamine is effectively reducing drug intake, just like we saw in the human laboratory. So what is doing all this work with self-administration? I'll show you just one example. Show you a bunch, but again, I want to get to the novel outcomes. Where's that gotten us? So we've got a model that has predictability. If we can knock down drug intake in the laboratory, we can be relatively confident that that intervention, that medication is going to knock down drug intake in the clinic. We've got a model that can be used to screen potential treatments. So not only, so we can maybe do this more cheaply. We can throw medications in to the laboratory for screening. And we've identified promising medications this way, which is great, really exciting. But none of them advanced for broad use for any number of reasons. It's because treatments don't just advance because they work. They advance for profit reasons, unfortunately, for social acceptability reasons. And if you want to talk about that, we can certainly do that at the end of the day. And another thing though is that self-administration can't be used in all populations, right? I'm using non-treatment seeking folks who are relatively healthy otherwise. That's a relatively restricted range of people that we can study. And cocaine use disorder is associated with a host of other problems, and not all of them are tied to abstinence and use. Again, I'm not saying that we move beyond abstinence entirely. I'm just saying we need to think about other things. So it's time to explore these outcomes. And so now we're into the point where I'm going to talk about the novel outcomes. But I couldn't come and not talk about self-administration. Like that's what I spent my whole career doing. So I'm going to talk about purchase tasks. Again, I know where I am. I know my audience. Attentional bias, inhibitory control, and decision-making. So drug purchasing tasks. I probably don't need to say this, but I'm going to say it anyway. These are commodity purchase tasks that have been modified to determine whether people will buy drugs across a range of prices. These are most often hypothetical, and they yield parameters like Q naught, which is sort of how much people will pay if it's essentially free. Usually it's actually if it's cost a penny per hit. And then alpha, which is a sort of change in P max over the prices, not elasticity. Maximum expenditure, all that kind of stuff. So I wanted to show you a little bit of the work we've done with drug purchase tasks in the lab. So this was a study where we're looking at phendimetrazine, which is agonist-like. It's a monoamine releaser like the amphetamine is. It's just not, it's a prodrug actually for a monoamine releaser, phendimetrazine, just not quite as potent as amphetamine. And we thought, oh, maybe this will work and maybe it'll be more acceptable, palatable to people than amphetamine is as a treatment. So we did an eight-session inpatient study. We maintained folks on 0 and 210 milligrams of phendimetrazine per day. And then we allowed them to administer doses of 0, 20, 40, and 80 milligrams of cocaine. And then we also had them do a purchase task under each phendimetrazine dose condition. So we were looking at both self-administration of cocaine under that phendimetrazine maintenance and purchasing. And we want to compare those outcomes to see if, can a purchase task tell us what self-administration task tells us? So that'd be great. And the bottom line is yes, but the results are negative to an extent. So number of drug choices, maximum of 10 in this study, cocaine doses across the y-axis, placebo phendimetrazine in the circles, active phendimetrazine in the squares. Cocaine functions as a reinforcer, typically what we see, phendimetrazine didn't change drug intake. Purchase tasks. Purchase a lot of cocaine, hypothetically, when it's cheap, drops off over, as the price increases. Phendimetrazine also did not change that. So negative to negative. I can tell you, we recently got positive to positive when I treated people with suvorexant, which is an orexin antagonist, increased cocaine intake, and increased cocaine purchasing behavior. So there is a correlation in self-administration outcomes and purchasing test outcomes. So I'm becoming more and more confident that we can use these, especially if we can't do self-administration in the population we're interested in. All right, so now we're going to move to other targets. So, I think I would argue that, there's clear relevance of drug taking and drug purchasing. There's face validity, right? People purchase drugs, people self-administer drugs. There's predictive validity of drug taking, of the drug self-administration models, and maybe that's there for purchase tasks too. But focusing again solely on sort of purchasing and intake hasn't gotten us an FDA-approved medication, unfortunately. And so there's a bunch of other targets that we could be thinking about. And I'm going to spend a little time talking about maybe some potential ones. These are certainly not all of them. The field is wide open for us to do this. So I'm going to sort of try to answer a range of questions about the sort of 3 areas, and not all of them will be answered for every type of outcome. Let me say that up front. But the questions that I'm going to try to answer for them is, can we model in the lab? Do they have face and or predictive validity? Do they have reliability over time? Because if it's a treatment target, right, you want that to be stable, except for when you intervene on it, right? Are they specific to cocaine use disorder? What's the clinical relevance, right? Like, are they tied to some sort of clinical aspect of the disorder? And can you modify them? Can you actually change them? So let's start with attentional bias. An attentional bias, sort of a formal definition, is it's an allocation of a disproportionate amount of time attending to drug-related, here cocaine-related stimuli. And this is typically due to incentive sensitization and or operant conditioning mechanisms, depending on which school of thought you're working in. The measures tend to be a cocaine Stroop task. There are problems with that, so we don't actually use that in our lab. We tend to use a visual probe task with eye tracking. And this was work that was led by Katie Marks during her dissertation. So here's how this task works. The line represents time. We show folks a fixation cross. Then we showed them 2 images. One is cocaine related. If you are not familiar, this is what a crack pipe can look like, but it comes in many, many forms, and a spoon. Now, I know that a spoon can also be drug paraphernalia. However, our folks are mainly smoking crack cocaine. For them, a spoon is a spoon. It's how you eat cereal or soup. It's not drug paraphernalia to them. And then we show behind one of the images an X, and we have them respond to the laterality of where that image is. And we take a response time measure. The idea is that they're responding faster to the X that appears behind that drug image. They were attending to that image. Indirect measure. So what we layer over that is eye tracking. So we have a little thing called a Toby that sits under the monitor, and we can get a heat map and get time spent looking at each image. So this is another one of our images. Telling somebody we had chopsticks as a control image. So here's that. Crack pipe, different type of crack pipe, control image of, sort of for sort of orientation and a little bit of color sort of interest. And so we've generally done this with eye tracking. So that's what I'm going to mainly focus on here. I'm going to show you some data about specificity and reliability, some data about clinical relevance, and some data about modifiability. So let's start with specificity. This is Katie's very first study into this. So showing you fixation time on the y-axis and showing you time 1 versus time 2 in a group that used cocaine, and time 1 and time 2 in a group that did not use cocaine. The blue filled bars are time attending to a cocaine cue. Open bars are time attending to that neutral cue, so the chopsticks, right? So in the people who use cocaine at both time 1 and time 2, they spend more time looking at the cocaine image than the non-cocaine image. The control group looks at both, right? They look at the cocaine images almost as much as the people who use cocaine do, but they also spend time looking at the neutral cue. Now, the question is, what are these folks doing? They're sort of looking off screen. They're looking at a bunch of different things, but then they keep coming back to the heat map shows us they're coming back to the cocaine. So it's relatively specific. The question is it drug specific? So we then looked at this a little bit differently. This is a paper that Joe published in 2019, and we brought people who use cocaine and people who use cannabis into the lab, and we showed them, we did the attentional bias task, but with cannabis cues this time. And so what we saw is that people who use cannabis attend more to the cannabis cues than to the neutral cues. And then the cocaine users people who use cocaine don't really attend to either that much, right? They're again looking off screen at other things. And for cannabis folks, we did see a response time difference as well. But again, this is a less reliable measure. We don't rely as much on that. The sort of direct fixation time measure. So it's drug specific. People who use cocaine don't attend to cannabis cues. People who use cannabis do. And it's reliable over time. And that first study I showed you would indicate that as well. So this is a study where Katie looked at a pool of data where we had gotten attentional bias on the same folks over time. And we let that freely vary. Like, some folks would come in a week later, some folks come in nearly a year later. And so we saw a reasonable correspondence between our attentional bias at time 1 and our attentional bias at time 2. It is far from perfect. That 0.26 is it's not a 1, but it is relatively stable and reliable over time. When we think about clinical relevance, so we're thinking about a range of sort of outcomes that speak to the severity or clinical sort of correlates of cocaine use. So looking at the years that people have used, the number of times they've used, how much they use in the past month or week, sort of other clinical correlates like impulsivity or drug abuse severity, test, DAS, nothing, not related to any of these attentional bias measures, which is disappointing and surprising. And it's not a power thing because this is like 60 or 70 people. So it's not like it's, just too small of a sample to get something. But it is modifiable. We can modify it. So this is a paper that Joe published in 2020. It's attentional bias, cocaine minus neutral. So higher is a cocaine bias, lower is a neutral bias. So we brought folks in and we either gave them, and this is a within subject study. So we gave them placebo or we treated them with 60 milligrams of methylphenidate acutely. We're actually able to drop that attentional bias with stimulation of their dopamine system with methylphenidate. And in fact, for some, we were even able to reverse the bias, push them towards the neutral cue. So just quickly about attentional bias. It's face valid, we think. It's reliable, it's specific, it can be modified. But wasn't tied to some of those clinical things that we think are important. I still think it's clinically relevant in that people are out in their condition attending more to cocaine cues than they are, but it just wasn't tied to things that we traditionally tend to think about as clinically relevant. Severity of use, times that they use in a month, those kind of things. All right, so let's jump to inhibitory control. We know the people who use cocaine display impaired inhibitory control. They are not able to, control pre-potent responses, sort of pre-programmed responses in the way that people who don't use cocaine are. And it's often tied to features like, so people who are more impulsive or have poor inhibitory control. Let me be a little more specific because Justin were here, he'd tell me impulsivity is a construct. So we're focusing here specifically on inhibitory control, ability to sort of control your behavior. We know that people who are poorer at that are less likely to stay in treatment and more likely to relapse to their drug use. The measures that tend to be used, you all are probably familiar with some of these stop signal tests, cue go, no go, attentional bias behavioral activation, or the ABBA task for those of you who are Swedish music fans. I'm going to focus more on these two, although I do have some data from the stop signal task at the end of this section that I'm going to share. So let me show you how these work just in case you're not familiar. So the cue go, no go test, we pulled this from the alcohol literature, who I'm sure pulled that from somewhere else. But here's how this works. Again, the arrow represents time. We show them a fixation cross. We show them what is a go cue. The cue is the orientation. So it's a vertically oriented rectangle. 80% of the time it fills in with the go target, which is the green color. And then they have to respond, right? So they need to press a space bar or something. So when they do that, they get feedback that they were correct. But, and this is the critical trial, this is the critical trial interest. Sometimes we're mean and we trick them. We show them the go cue, so again, the rectangle oriented vertically, we fill it in with a no-go target, a blue color. So they have to inhibit, they're ready, like 80% of the time they're ready to respond, right? They want to do well on this task. But 20% of the time we fill that in with blue. And so what we're interested in is the number of trials they fail to inhibit this behavior when we mess with them and we change the on them. So the data I'm going to really be showing you are the times when we have done this to people, okay? There, of course, are controls in that we show them a no-go target reliably, fills in blue, so we can also be looking at errors of commission, errors of omission, but we're more interested in that controlling that time to respond, I got to respond, okay? The ABBA task flips that just a little bit in that we show them one of our attentional bias pictures, cocaine picture, and that can be a go cue. We are priming them to respond in the presence of the cocaine cue. Again, fills in with a go target 80% of the time, 20% of the time it fills in blue and they're supposed to withhold that response. Okay, so in cocaine use disorder, we've looked at influence of cocaine cues. So that's that ABBA task. I'm going to show you that first. We've looked at specificity to cocaine use disorder. We've looked at clinical relevance. So again, some of those clinical features that we're thinking about and whether we can modify it. Okay, so this was, again, Erica led this. A lot of this was her dissertation work. So this is proportion of failures, again, after we have shown them that no-go cue when they're primed to respond. So when we're showing people who use cocaine image, it's really bad. 20% of the time they're unable to withhold that response. Whereas for neutral, it's about 5%. So not bad. That's about standard. That's about population control levels. All of us have an error rate on this type of task, but it is not specific. People who use cocaine, people who use controls. So people who use cocaine on the left, controls on the right. Again, everybody does badly when we show them cocaine images and we want them to withhold responding, which is really interesting to me. And then they do better when it's a neutral cue. So it's not specific, at least, which is why this is unpublished, I think. Sort of like attentional bias, we looked at a range of sort of clinically relevant outcomes, years of use, number of positive urines they have when they're screening with us, days of use, impulsivity. Again, none of it is tied to inhibitory control performance. But to close on the bright side, we're actually able to modify it. So we used the ABBA task, but we flipped it. We trained people to inhibit their responding in the presence of a cocaine cue. So the cocaine cue was a no-go cue in the training. We also just had a neutral, right? Neutral training. Just show them rectangles, they filled green or blue, right? Sort of like the standard task. But then we didn't want to have them tested on those inhibitory control tasks because we had just spent all day teaching them to inhibit their responding. So we used the stop signal task as our sort of outcome measure. The point is pre-training to post-training, regardless of the task training condition, whether it was cocaine cues or neutral cues, people get better. So they're spending all day in the lab with us, which is exhausting, learning this task, and they're still better at their inhibitory control at the end of the day on a separate task. So it is modifiable. All right, so inhibitory control, impaired by cocaine cues, but in everybody apparently, and modifiable under acute training conditions. Again, cue effects are maybe not specific to people who use cocaine, and we haven't done any work around reliability. We haven't done test retest stuff in folks. And I think it's clearly clinically relevant. I think we know that inhibitory control is related to drug use, but we fail to observe a relationship with a range of cocaine use sort of behaviors. All right, so last little bit of the talk is decision making. We know that non-optimal decision making is a hallmark behavior in people with cocaine use disorder. We know, I'm looking at Richie, where you know that they choose smaller, sooner rewards. Like we know that is consistently shown. Looking at Michael Amlin, who's published the meta-analysis on this, that it's a transdiagnostic thing, that there's delayed discounting issue. I'm not going to talk a lot about delayed discounting, but we know that that's sort of a hallmark behavior. We have looked at risky sexual intent. We have looked at decisions about losses and gains. We've looked at decisions based on reward or punishment and decisions based on the presence of drug cues. And almost all of this is Justin. So maybe you've seen it, maybe you haven't. And this is one where we haven't answered all those questions because Justin was like, I want to measure all these behaviors. So we didn't do as much sort of like reliability kind of stuff. But really still, I've got some fascinating results to show you. Okay, so first looking at risky sexual behavior. This is a delayed discounting framework actually, but it's not delayed discounting about drug use. It's delayed discounting about risky sexual intent. So we're asking people to look at pictures. This is a task developed by Matt Johnson and Natalie Bruner, and they're looking at pictures and saying, pick a picture of somebody you want to have sex with. Pick a picture of somebody you want to have sex with, but you least want to have sex with. I never quite understand that outcome, but and then pick a person who you think is most likely to have an STI or least likely to have an STI, and then tell us, you're not in a relationship with them, and you can have sex with them either right now without a condom or after some period of delay with a condom. And we know that from Matt's work, the likelihood of condom use decreases as a function of increase in delay, right? So what we did was we did this in folks. This was a larger study where we looked at self-administration and all that kind of stuff. But we also happened to use this risky sexual intent task following treatment with placebo or buspirone. Buspirone's a serotonin drug. For a while, NIDA thought it was the cure for cocaine use disorder. It is not. It didn't change cocaine intake, but what it did was across these measures, so buspirone is in the black, placebo's in the open circles. Across all these measures, buspirone reduced risky sexual intent. So higher is better here on this curve. So across all measures, wanted to have sex with the person who has an STI, they endorse more likelihood of waiting to have sex with a condom than not. So while buspirone didn't change drug intake, it might help us with risky sexual intent, which is what we think is driving that HIV figure I gave you at the beginning, right? Because we controlled for intravenous drug use and people were still more likely to have HIV. So we think it's risky sexual practices. Okay, so next, decisions about losses and gains. This is the endowment effect. This is Daniel Kahneman's Nobel Prize winning stuff. So for those of you who aren't familiar, the initial work around the endowment effect was with coffee mugs. And they were asking people, how much would you pay for this coffee mug? Or if you own this coffee mug, how much do we need to pay you to buy this coffee mug? But Justin's thesis, master's thesis was about this. We noticed that a lot of our folks who were coming into the lab had like headphones, like they all have smartphones and they were, listening to music on the headphones every time. They just sit in the waiting room. So we were like, well, let's get some nicer headphones and look at that too. So this was actually realized. We had mugs. We actually found a box of mugs the other day and people were like, why do we have all these coffee mugs? From Justin's thesis. We don't have any headphones left. And then we did it hypothetically for purchasing crack. We didn't actually have crack that people could buy and sell, but we did it hypothetically. We also, there's this sort of endowment effect measure that's about gambling behavior. Like, are you willing to accept a bet or not accept a bet based on the odds, right? Like of a coin flip. Basically, if you flip the coin and heads, you win $10, but tails, you lose $5. Will you accept that bet or not? And so Justin's thesis looked at this. So riskless is just the purchasing, that mug, those headphones, you're gonna get those, right? Risky is the gambling. So let me set this up for you. So that's the black bars and the white bars, the non-drug commodities versus the drug commodities. Again, the drug commodity is hypothetical, the non-drug commodities were real. So what I'm showing you is the loss aversion coefficient, or lambda, for this. And because loss aversion or the endowment effect has been studied ad nauseum in people, we know that in general, lambda is about 2 for norm, give or take. So that's why this bar is at 2. So basically, on average, in the population, somebody values what they own twice as much as what they would buy. Okay, so that mug is worth $2 to me, but I'd pay $1 for it. Okay, we found that with people who use cocaine across commodities, across risky and riskless, they're much more rational about their possession than about what they pay. Their lambda is right around 1. So the coffee mug is worth $1, and I'd pay $1 for it. Okay, next one. Again, I told you, Justin was like, want to understand all these types of decision making. So next was a reward and punishment. This was something we took out of the Parkinson's literature. Looking at positive outcome trials, where we show them an arbitrary image, sort of, and ask to categorize, is it an A or is it a B image? And correct responding, so let's say this was an A image and they said it was, they get 25 points. If it's an A image and they said it's a B, no program consequence. So then we flipped it, and in certain outcomes, there's a negative outcome trial, where, again, show them an arbitrary image, an A or B, correct? So this is an A and they say it's an A, they don't get anything. But if it's an A and they say it's a B, they lose 25 points. So positive, negative outcomes from learning. And looking over time in terms of proportion optimal choice as a function of positive, okay, so reinforcing that behavior, or negative, punishing incorrect responding. People who we brought into the lab, so we knew they were people who used cocaine, people who we sampled through MTER and indicated they were using cocaine, and then non-cocaine using folks. People who use cocaine are pretty bad at learning from positive reinforcement. They learn just fine from negative. Folks who are control do fine for both. What I want to point out here, and we've not followed this, and this is another thing that I just is in the back of my brain that's important to do. This is what this is the profile of somebody who's unmedicated who has Parkinson's disease. They do not learn from positive reinforcement, but they learn from negative. If you give them a dopamine agonist, it switches. They do just what they look like the controls. They learn from that positive reinforcement. So I think, that's sort of that underlying dopamine effect that we've been talking about, why amphetamine maybe works, why methylphenidate reverse attentional bias, right? So that may be operating here as well. Okay, so last thing I want to talk about is drug cues. So because it all ties back to that attentional bias, ABBA, Justin wanted to do something similar. So he brought folks into the lab and we showed them a fixation cross. We showed them 2 images, cocaine-related image, control image on the right, and then underneath are 2 monetary values. And we asked folks, pick a monetary value, right? So here it's even, 5 cents or 5 cents. Sometimes, it would be 6 cents, sometimes it would be 5, right? So we're asking folks to sort of tell us which value you'd prefer. And they actually got this money, I think. So, and when Justin brought this task to me, I was like, what is it about? Like, what's the purpose? And I'm still wrapping my head around it, but I think the data are pretty interesting. So when we bring in folks who use cocaine, they tend to pick when it's 5 cents and 5 cents, for example, they tend to pick the cocaine associated value, which is interesting. It's just something about that cue is imparting value to that even though they're even. Whereas to the control group, they tend to pick the non-cocaine cue. But they're pretty good, like picking the greater valued item. But still, some people who use cocaine will pick a disadvantageous option that does happen to be associated with cocaine cue. And it's somewhat specific in that, again, we look at the cocaine cue here, again, relative to the different choice. When it's even, they tend to pick the cocaine associated image item. Again, they still will sometimes engage in some disadvantageous behavior, but if we have them pick between neutral cues, they're just fine at it. They pick the new, you know, they pick either option 50% of the time. So it's something specific to that cocaine image in that population, something specific to that cocaine image in the people who use cocaine versus those who don't. Again, still don't exactly know what it means, but Justin was really excited to run this study. So decision making. So it's the newest area for us. Like I said, I don't have, well, we've displayed differences in people who use cocaine along a range of domains. And I think that's an initial first step. You know, we were talking earlier about, you know, a lot of this work is about showing deficits, right? Which is fine and important first step, but you got to move beyond that. We may be able to modify it, at least for risky sexual intent, which I think is pretty interesting. And we've been able to show some specificity to people who use cocaine versus those who don't across a range of these outcomes. You know, I've been thinking a lot about, you know, I'm not a super theory-driven person. You know, I believe in behavior, believe in pharmacology, but I'm not somebody who's like, you know, what is the grand theory of addiction? That's just not something I spend a lot of time thinking about because I tend to focus more on the clinical condition. But Rick Lamb and Brett Ginsberg in 2018 wrote a paper about addiction being behavior allocation disorder. So not being, you know, a brain disease, not being a moral failing, that it's about behavior allocation right there. And I think that all of this data, but especially these decision-making outcomes fit with that, right? That it's just this allocation of behavior, not all the time, but predominantly to a drug condition or a drug cue. But we have so many other things to do with this. We have so many other parameters to evaluate liability, specificity, clinical relevance, if we want to advance these as ultimately the treatment targets for the FDA. Okay, so just quick wrap-ups. So what do we know? Where do we go? I think hopefully I've convinced you that the human laboratory model allows us to evaluate mechanisms and behaviors underlying cocaine use disorder. And we've got some predictive models, which is great. These other outcomes model important behaviors related to cocaine use, and we have more work to do there. Like better understanding their clinical relevance to these targets, and testing interventions, how they impact these targets. You know, we've done a little bit of that in the lab, but like really the next step is to move that out into clinical trial. I think we need to understand how these novel targets and changes in these behaviors relate to cocaine taking, both in and out of the laboratory, right? Because while I want us to move beyond abstinence, we're never going to not think about abstinence and non-use, right? It's always going to be part of how we diagnose the disorder, right? And I think we've also got to, you know, get complicated with it. We've got to be looking at combination approaches because all of these behaviors are what make up the problems that are posed by cocaine use disorder. So we've got to be thinking about all of them at once, and that's daunting. But that's why all of us are in this room. That's why there's this field of folks doing this work, because it takes so many people, it takes multidisciplinary, it takes teamwork and collaboration to get at the issue. And with that, I will close and be happy to take questions. Told you it was going to be a whirlwind.
Great talk. You mentioned before about like social acceptability and this idea is definitely to make that worse. It's just sort of curious. So obviously for like opioid use disorder, we have methadone. But even in your study, you're looking at cocaine use for that.
Yeah.
But given that these things have similar mechanisms of action already, is there some prudence to not just giving the same agonists as the therapy? You know what I mean? Giving small doses of cocaine to reduce the cocaine behavior. And the idea being that social acceptability would probably plummet. But the idea that you're doing this,
Yeah.
much like
Sure. So yeah, I've got a couple reactions to that. So, you know, I mean, I think for agonist treatment, yes, you want your agonist to look as much like the drug you're studying or you're trying to treat as possible, right? So, so in that instance, yes, the idea of treating somebody with cocaine who has cocaine use disorder is palatable. And, you know, I think that if we're talking about opioid use disorder, the UK has actually done this, right? Like you can get, if you have a think the term is intractable opioid use disorder, you can get heroin and syringes from the government. So then you've got a clean supply, you've got a safe supply, you're not overdosing. I think some of the issues with providing cocaine to people, social acceptability aside, right? Like I think, I think that for the same reasons we could think about cocaine, right? Provide a safe supply, provide, clean or clean use, right? Methods for use. So clean pipes, clean needles, those kind of things. But I think your point about, like pharmacokinetics is important, right? Like cocaine is quick on and off, right? Like, so it's 45-minute half-life. And so you'd have to sort of engage in a lot of repeated use for those folks. And that's why drugs like amphetamine are maybe more effective, because you take one pill in the morning or one pill and right? Methamphetamine works for cocaine use disorder, right? Methylphenidate doesn't work quite so much. And I'm going to get to a pharmacological point in a second too. But yeah, no, I mean, it's a reasonable thing to look at, right? Like, and you could do oral dosing of cocaine because you can eat cocaine and get an effect, right? And so folks have thought about it, and the reasonable thing to do, it just isn't something that has gotten a lot of traction. But there's also a pharmacological reason why you might want to study a releaser like amphetamine for cocaine use disorder. And my mind was blown. I saw these data at a conference in Maine. Is that like and this is preclinical data, but animals who are self-administering cocaine, like those dopamine transporters will sort of like glom together. And when you give them a releaser like amphetamine, it breaks those apart. Whereas if you give them and this is work out of Sarah Jones' lab, Cody Siciliano was doing this work, and I'm oversimplifying it. So like there's some pharmacological mechanism of a releaser that is beneficial for dopamine transport inhibitor like cocaine. And so anyway, sorry, rambling answer, but not a bad idea and certainly worth considering. Again, make your agonist as most agonist-like as possible. So make it the drug. But I think there's probably some pharmacological issues that we have to navigate with it. Good question. No. Yeah.
Comparing to alcohol, where you can say if we just have drinking, then it's okay. But for those controlled substance, we can. But that has something to do with. But what's the reason behind that? Does that have something to do with?
Yeah, I mean, I think there's a number of different things. So I think, one, we need to acknowledge that for alcohol use disorder, that development is only relatively recent, right? It's what, last 5-10 years that this has been an accepted outcome. And there was a lot of science that went into it, right? They were reanalyzing data from Project Match and all these sort of big clinical trials, and were able to demonstrate benefit of eliminating heavy drinking days. So I think that's part of it, right? Like it's just a data thing. Maybe it's a controlled substance versus not, even though alcohol is, probably more harmful than a lot of these other drugs. But I also think it's just this notion that people can drink and be normal, right? And be fine and drink a little bit, or maybe even drink to excess, but maybe not have heavy drinking. Whereas like you should not use any drugs ever, right? And I'm not here to tell you whether that's right or wrong, although you can probably guess where I'm coming from with a harm reduction background or focus. But yeah, no, there's this idea in society, right? You should never use any drugs ever. Drugs are bad. You should always say no. That's sort of the abstinence focus that probably drives a lot of that decision, right? Has to be about abstinence. So yeah, I think there's probably something to the fact that they're controlled substances, they're illegal, right? Yeah. So, Michael.
Can we talk for a second about stigma around
Sure.
this? Because I found it interesting. You think about powder cocaine has many different sort of histories, but often it was kind of at big high society parties, and with white collar stockbrokers and things. You'd see it in movies, you'd see it in novels and things. It wasn't until it became a crack cocaine problem that it seemed like a lot of this kind of stigma came around.
Yeah.
So, how do we break that down?
Yeah. Oh my goodness. Okay. So I'm going to try to give you a 3 or 4 minute answer to like a year-long right? Like probably could take a class about this. So yes, absolutely, right? And I forget the movie, but like there's a movie where like they're like powder cocaine is a fun drug and crack cocaine is a bad drug, like and that persists today, right? The glamorous, Studio 54 powder cocaine, people walking around with spoons on their necks, and I'm thinking about Whitney Houston giving that interview where she's like, I don't smoke crack, crack is for poor people, right? Like, so there is that sort of media perpetuation of who uses crack versus who uses powder cocaine. I think that translates into the sort of different criminal justice punishments for drug possession, right? Like, so where possessing amount of powder cocaine gets you 1 sentence, possessing that same amount of crack cocaine gets you a much heavier sentence. Now, Barack Obama eliminated some of that, but there is still a sentencing disparity between possessing crack cocaine, possessing powder cocaine, despite the behavioral pharmacology data showing us that powder cocaine, when injected, is the same as crack cocaine when smoked. Does the same thing. So I think, I think we've got to educate people about that, right? Like they are not different. They are the same drug. They might look different, but they don't feel different and they don't act different. And one is not any less or more dangerous than the other. But I think the other thing, we have to acknowledge is, as a society, that there was this perpetuation of this myth. Perpetuation of this myth, let's say that, I would say it that way, that crack cocaine was dangerous and was going to make people violent and they were going to rob you and kill you, right? And that was just, and then there were the crack babies, right? And so we are all living with that media perception, and we've got to use the science to combat that, right? We know that those kids who were exposed to crack in utero maybe displayed some deficits early on, but they caught up, right? Those kids are not any worse off than the kids who weren't. I'm not saying we need to expose kids to crack. Let me be very clear, but we need to combat that myth of cocaine exposure, is it's a moral failing, and these women deserve to be jailed, right? Like that's just all terrible. We as scientists, the onus is on us to fight back against all of that. So sorry, quick answer, maybe a little bit on a soapbox, but yeah, sure.
Super simple question. So the data you showed from the decision-making task, where you showed normal responses to punishment, but then kind of the lower non-sensitivity,
yeah,
whatever.
Yeah.
Right, and you saw that, so that it's the same for individuals with cocaine use disorder and participation, right? So kind of neurochemically, that kind of makes sense to me, right? So lower responsiveness in the kind of the midbrain dopamine system. What is happening neurochemically when punishments occur where that is not impacted? Do you have any thoughts on that?
I think, you maybe start with the answer that maybe that it's not as dopamine reliant as, responding to a positive reward. But yeah, I don't know. And in fact, I think the Parkinson's literature, they looked at it a little bit and try to figure out like, is there a way that not get them to learn less from negative reinforcement, because you don't want to make them worse at anything, right? These are folks with Parkinson's disease. But yeah, I don't know. I don't, and that this idea is one I keep coming back to is like I think we probably need to look at it. And again, it could support the dopamine stuff. But yeah, I don't know. I don't know if we need to look at some sort of other system. Is it acetylcholine? Is it, I don't have a good answer. But I think also probably because they're pretty good at that, right? So we need to find a population that is bad at that and figure out what that pathology is to get it to flip. So sorry, not a great answer, but there's a few of these. Every time I give sort of this this talk or a version of this talk or show those to you. And I'm like, yeah, we need to get back to endowment effect. We need to get back to this learning.
Well, I mean,
Yeah.
what I, it's not my area, but sounds like it's the case here is that we seem to know a lot about reinforcement.
Yes,
processes.
yes.
We don't seem to know much about kind of punishment process,
Right,
right?
right.
That's like certainly the case in neuroscience, where like when I ask somebody, a neuroscientist, what is a negative bolt signal?
Yeah.
I still don't know if there's like
Yeah,
a good answer.
Yeah, no, I agree. Well, I mean, I think the other thing is I think we think about, right, like people who use drugs are chasing that positive reinforcement. Not always true. For opioid use disorder, they're chasing that negative reinforcement, right? Like they at a certain point, they're trying to avoid withdrawal. I think that for cocaine use disorder, we don't have to think about that quite so much. But like more broadly, we know that reinforcement of behavior works as a treatment, right? So they can respond just fine to those. And we know also that punishment doesn't work. Putting somebody in jail does not prevent their drug use. And in fact, might make their drug use worse. So that's something that I'll like that the flip of that task, like, is not working in real life, right? Like they respond to positive reinforcement and not to punishment, right?
So, to add on to that question, does that behavior, works for all kinds of drugs, or if those people are with alternatives, will that result in it?
So I don't know that anybody, so at the time we did this, I think we were like the first group to really adapt this into a drug using population, that specific task. I don't know if anybody's followed up with it. I should probably should. But yeah, I don't know the answer. I would hypothesize that it's probably a little bit universal across people who use drugs, but I don't know that to be true.
Okay, I think we'll go ahead and stop there. So join me in thanking.
Thank you all. And email me if we didn't get to your question.
So
Yes.
for those of you that RSVP to the training lunch, we'll be upstairs on third floor in the Cofrin Logan Center in the conference room. If you are a trainee